that none of us have the power to solve on our own, but by coming together, by supporting each other, by supporting this community, I think we've seen that really positive things can happen. There was a lot of mention of progress over the last 20 years, 15 years, 10 years, and that has certainly been the case, and it's been remarkable to see. The vast majority of that credit goes to the doctors and researchers who have tirelessly worked to improve care for this disease, to continue to perfect surgery and radiation, and in recent years to develop new systemic therapies. And truly, it's been remarkable to see, even just during my 18 years of dealing with this disease, how the field has progressed. It's remarkable to see those continued advancements. Dr. Sen, who's our next speaker, is going to talk with you about a even bigger picture perspective that spans Dr. Sen's more than 30-year career, which has been in large part dedicated to chordoma. And I think we'd be hard-pressed to find anyone in the world who has really devoted more of himself to this disease. I'm sure Dr. Sen's not going to mention this, so I'll brag for him a little bit, but just to give you a sense of Dr. Sen's dedication, Dr. Sen's now a professor at NYU, but before that, he was funding chordoma research out of his own pocket because he cared so deeply about improving the care for this disease. I think that just really speaks volumes about the dedication that Dr. Sen has to this disease, but truly the dedication that so many clinicians feel towards this community and towards this disease. And we're going to hear from Dr. Shuba and Dr. Alonso Basanta as well. We are so fortunate as a patient community to have physicians that care so deeply and really devote themselves not just to patient care, but to pushing the envelope to improve that care. So Dr. Sen is going to talk about improvements in care over the last 30 years plus in this disease, and also talk about some of the advances that are on the horizon. So just a quick note, Dr. Sen is the Bergman Family Professor of Skull-Based Surgery in the Department of Neurosurgery at NYU. He's the Vice Chair of the Neurosurgery Department, and a true world leader in chordoma care. So Dr. Sen, over to you.
Good morning, everyone. As Josh said, I've been in this journey for many years, and with many people, maybe some people in this room. So this was the first paper I published in 1989, and this was on chordoma. There was hardly anything, when I was writing this, hardly anything in the literature that I could really solidly refer to. So that's the beginning of my journey with you all. So I'm just going to stick to clivochordomas. That's my area of interest, and it's a very rare disease, as you all know. Another misconception people have, it is a malignant tumor. So many people come to me and say, oh, somebody told me it's a benign tumor. Even this day and age, when there are so many publications out there. So that's something one has to understand. And the reason one has to understand is not to scare the daylights out of you, but to take it seriously, that it has to be treated properly. You can't just play with it and go to the next door clinic to get it treated. It's a progressive disease, and eventually it can be lethal. But it's like so many cancers we deal with in life. The other thing is, this is a locally aggressive disease. It's not like something that spreads everywhere in the body. So that gives us a little window of opportunity, at least for the skull-based tumors. The spine tumors is a different story. And because it's a rare tumor, not too many people have a lot of experience with it. So that's why you hear all these different stories that you heard. One person says this, one person says that. How does a patient decide? It's almost impossible. If I go to, fix my car and get two opinions, they are the experts. They will tell me what to do, right? So it's more than that, it's not just fixing your car, it's something else. So the chordoma begins as a notochordal rest. And what is the notochord? It is this part that you see here. This is the embryo in which the ectoderm, there are three layers. The ectoderm makes a track between the ectoderm and the endoderm, and it's called the notochord. And the notochord is an essential thing. You cannot develop, nothing will survive. So it's so important. Now the brachyury gene is what triggers the notochord. And this is a gene that was discovered and reported on not too long ago. It's found only in the embryo. By the 12th week of gestation, the brachyury is no longer expressed, but the chordoma expresses it. So something makes it wake up again. And that's what we are trying to find out. So this was a great paper that was published by the group in University College London, and they described the brachyury gene, and it's how it is found in the notochord, and it's the single most important identifier in a chordoma. So unless you have that, it's not a chordoma. So what are the results? This is sort of, I will trace to you my history. So this is where the chordoma sits in the skull base. You can see it's the center of your head. It's completely underneath the brain, surrounded by all kinds of things. Very, very crowded place. And a lot of important activity going on there. But if you look at the history, these are the survival functions over the years. And you can see that on the right side, you will see the years that these graphs were plotted. With time, the survival has improved, starting over 30 years ago, which you heard already. And why is it so? We have better scans. When we started out, when I started out, we had CT scans still. In 1985, when I finished my fellowship, and CT scans. Now look at the fancy imaging you get. You can see everything virtually. Surgical techniques have improved. Specialization has occurred because there are people who just specialize in this, because I may be seeing 6 chordomas a year. How do I keep my expertise? That's important, right? Numbers are what makes you an expert. The more you do, the better you know, the better you can treat this. It's a rare disease. We won't see that many more. And then radiation treatments have improved. You'll hear that. And then what is missing is drugs. Still missing is drugs. I mean, there are some trials that are throwing some light on it, but that's where we are now. So these are my results from 2 groups of experience I tracked, 1991 to 2005, and then 2006 to 2020. And the message is clear. If you can get a gross total resection, you are way ahead in the ballgame. That is a known fact. And everybody's experience proves that. How do we go about it, and what price do we have to pay for it? That's the question. How do we keep the morbidity low and the outcome better? So what are the factors that affect it? Degree of resection, number 1, trumps everything else. Radiation, there are many different forms of radiation. So it's hard to compare one to the other, because people get a smattering of radiation treatments. Then there is a biological factor too, because some chordomas are inherently more aggressive than others. We have done some studies to determine what is what. So what about the degree of resection? Because that is the only thing in our control as a surgeon the first time you see us, is the degree of resection. And we start with the premise, the more is better. Where do we stop? That's where the judgment comes in, on having done these things over many years. So it's the primary or a recurrent tumor. If it's a primary tumor, your shot is better. If it's the size, if it's big, less chance of curing it. Location. as you saw in that picture, and relationship to major blood vessels. Then the other question that comes up with clival chordomas is that what does surgical technique tell us? Is it important to get unblocked resection or a piecemeal resection? And the things are different in the skull base and spine, which you will hear. So these are really the variables that we have to deal with. So there has been a major shift in treatments, and I have lived through this because I started in the era of open surgeries, last big operations, and then currently now everything is endoscopic. Since 2010, I would say I picked up the endoscope in 2005. It was a big learning experience for me because I felt that it was such a major improvement in surgery. So if you look, this is where the chordoma sits. So we put an endoscope through the nose, and this is what we are looking at. This is where the chordoma is sitting. It's in the middle of everything, and no easy way to get at it. So I compared my own series, so which sort of resonates with the other series too. So the first series we compared 65 patients, clival chordomas, and open approaches up to 2005. That's when I started the endoscope. So we had these big openings in the skull, opened the craniotomy, and then, so we published that at that time. I compared it when I picked up the endoscope. Did it make any difference? Because I'm keeping myself as the constant factor, and I'm comparing my results with two. It's so apples to apples comparison. So 68 patients, more or less similar. This now we're doing through the nose. So compared to those big openings. So basically, the conclusion is that still radical resection is better, but we got gross total resection in only 58%. So not a great track record. Still, we try our best, try to minimize morbidity, but still we find out that the tumor size, where it is located, and if you had surgery or not. What about comparison to the second year of my experience? So we saw that the complications were a lot less, except for CSF leak, 81% complete resection. And the progression-free survival, unfortunately, was about the same. So even though we got 58 versus 81%, that means we are leaving some microscopic disease behind. We have to accept it. As surgeons, we hate to accept defeat, but this is where the reality of life is. So these are the comparison. You can see the degree of resection versus on left to the right, two different eras. And also, in the early part, we used to do like staged operations. 1, 2, Sharon, you remember? We used to, so that has completely almost minimized it. And you have to accept this, big operations have risks, and these are the complications. These are like in anybody's hand. So this is an example of a man I had seen. He lived in Georgia at that time. Came with this, he was a postman. And he was seeing double, that's all he had. Only double vision from this big monster sitting there. And that's how people will find out, most people. So I did 2 staged operations, big craniotomy and then endoscopic approach, and this is the resection. We got a good resection, went back to delivering mail, went back to Georgia, but you see that there is something there remaining, way down at the lower pole of the tumor. It's a tiny piece, it's very small. We monitored it, we gave it proton radiation at that time. He worked. Tumor came back, after 11 years he passed. So, sad. So location of the tumor makes a difference, how much you can get. So this is a young man who I saw, who was having difficulty breathing. When he would lie down, he couldn't breathe, so he had to lie on, propped up in 4 pillows. That's how he found this. That's all he had. Couldn't breathe when he lay flat. So this is the tumor he had pushing into the brainstem. And this is the bone involvement you see, because this is a bony tumor. You have to address that. This is the post-op scan. He's now 10 years post-op, no radiation. So I am choosy about who I radiate. because I don't want to use up all the weapons in my armamentarium. So lower clivus, this is a tough problem. You can see this is a young girl. She was 7 years old when I saw her. And this is the tumor. You can see it's got lumps and bumps everywhere. Hard to find. You can miss a bump here. You can miss a lobule there. Even with the best of visualization tools. So I operated on combined through the mouth. And this is, we are working with the endoscope through the mouth. This is C1 being taken down. And this just to give you an idea that we are working just through that small opening with long instruments. And here's we are delivering these lumps and bumps out. And then this is the clival dura, which is partly invaded, and we are cutting it out. So all we are doing is working through the mouth. This is the hypoglossal nerve, and this is the dura of the brainstem. So then we are closing it up, and this is her scan. She's 19 years. She finished college. She's working. She got radiation also, proton. And so there are good highlights out there. So I like that. Otherwise, hard game to play. So there you are. This is the scan, and she's wonderful. She's so sweet. Some operations we still have to do in 2 stages. So this is an electrical engineer who came to me, again, double vision. All he has is double vision. Look at the tumor sitting inside the brain, all major blood vessels involved in this. Then it goes down into the clivus, lower down. So this one I decided to do it in 2 stages because of its location. So this is the first stage through craniotomy. This is the middle cerebral artery. This is a major blood vessel. And the tumor is around the branches of the middle cerebral artery, which is very, very tricky because if you injure any of those blood vessels, you can wake up paralyzed with a stroke. So this is his first operation. And then you can see it's how it's stuck to some branches of the carotid and the middle cerebral. This is the posterior communicating artery. We're drilling it out. And this, now we went through the nose to remove the rest of it. So I spaced it about a month. And this is what we are doing, working through the nose. This is the pituitary gland, carotid, cavernous sinus here. And this is the post-op scan. He also got radiation. He's 4 years post-op, he's working. This is a young girl who was a nursing student. And she was having difficulty walking. She came in limping, one side was not working. And you can see this big thing. And so this I had to do in 2 stages because this part is in the brainstem. This is sort of, I couldn't reach it. And this is the part that I did in the 2nd stage, remaining. And so this is her scan. She got proton. She's 13 years. She finished. She's a working nurse in OB. So you can have good results. You know, it's sometimes it's not always depressing for us, you know, because you patients live from scan to scan. I hear everybody talk. Oh my God, I can't sleep for 2 nights before my MRI. So I too can't sleep before your MRI. So it is like that because I hate to admit failure. So if I see something bad on the MRI, I say, God, what happened here? And then so different problems. It's your life and it's my result or my ego. So here is a little problem. It's called the chordosis. Small thing. The guy comes with a dripping of fluid from the nose. That's all he has. MRI is done. Somebody says, oh, it's a chordosis, nothing to worry. Is it a chordosis? Is it a chordoma in the early stage? Still don't have an answer. So here here's some fluid in the sphenoid sinus. We went in, repaired it, took out the tumor, and this is the pathology. It is a chordoma. So tiny. People would say, leave it alone, watch it. No. When it is small, that's your best chance. Never lose that sight. I know you want to tell the patient, oh, we'll just watch it, don't worry about it, nothing to, no, wrong thing. So this you see is staining with brachyury, and Ki67 is very low. So this is, these are some results. The Chinese people have the biggest numbers in the world. Amazing, because they go to these centers. So, and these centers are 5,000 bed hospitals, and that's where they get channeled. So it's not like you go to a community hospital, somebody has done 1 in 5 years and will do it. It's not like that. It is, they are sent to a specific place. And even their results are the same. Look at the 5 and 10-year-old survivals. Then this is another way of prognosticating. So this is from the Pittsburgh group. They found out what genetic abnormalities are there in these tumors that predict some are bad actors and some are not so bad actors. This is another thing. Again, they look at different things that predict their. So this is also another thing about where does radiation play? And Josh, am I off time?
Almost.
So if you look here, this is, my son put it together. He's a neurosurgeon, and he is interested in this stuff. So you can see that the left column is surgery alone, the right column is surgery with radiation. You can see that there is no clear-cut answer that with radiation you are completely averting the disease. It's not, at least that's the current literature. But you'll hear a lot more of it because these things are taken over long periods of time and the science advances very quickly. Not very quickly, but relatively quickly. So you can see that if you still get gross total resection, there is no clear-cut advantage of radiating right away. That's my take on it. That's why I like to keep it in my reserve, in my back pocket. What do you do if you have a recurrent chordoma? Tough problem, very tough problem. Either you radiate, therapy, or reoperate. And you look at this, yes, it's possible to radiate. You can give a hefty dose again, but your results are still not going to be as good as it was the first time. So this is the journey. In a patient's perspective, when I started, patients had no place to go for any information. They were totally lost, as were many doctors. They had nowhere to turn to get information, no reliable source, and they had no idea what kind of problem it is and what to do about it. What's their life going to be like? Then comes this. So I met Josh first when he started his journey with his problem, and he and his mother and God, bless both of them for starting this organization in 2007, and I'm part of it since then. And this has really made such a humongous difference. The first Chordoma workshop was 2007 at the NIH. Only 50 people were there, scientists, 50 scientists and doctors. 2016, there were 300 people. So can you imagine the impact of Chordoma Foundation? That's all I would say. Look at this. This was a slide from 2016, 10 years. They supported research, they supported patient care, and they supported the healthcare initiatives. So in all three parallel paths, they were pushing the boundaries. And look at all the milestones that they achieved. This is truly a remarkable organization. I'm preaching to the choir. So this was how many trials they had. So this is what I spoke with Josh about the other day. They've given 105 grants. That's where your money is going when you give it. 14 clinical trials to date have been supported. There were 2 publications put forward by them establishing the standards of care for primary disease and recurrent disease. So they have really tried to standardize the approach to this. This is like a AI search I did. So if you look at it, the Web of Science, this is surveyed the PubMed. In 65 publications in 2007, 200 publications 2023. So a rare orphan disease that affects 1 in a million, there are 300 papers about it. That's like unbelievable. The molecular biology, another thing, we never, when I published the first paper, I had no clue what this tumor is all about. And look at the papers now. 50 to 70 papers in 2003 just on studying its genomics and the molecular biology. Chordoma specific trials, there are only 2 or 5 in 2007, 14 now, and 66 broader trials that include chordomas with other things. I'm very fortunate to work with this group of people. These are my basic science team, Dr. Zagzag, Dr. Snurro, and Dr. Garnier. They do a lot of basic science work. It's really amazing. It really puts it together as a team, because I do the surgery and these people study the biology of the disease, which is what we are trying to understand and hopefully be able to intervene and treat. So with this I will end, and thank you so much, and thank you, Josh, for asking me.
Chandra, so remarkable, your dedication over all these years. I think in the interest of time, we'll save questions for